Thank you everyone for joining. It's our last session of the day here. This is causal inference via trial emulation. And Dr. Nandita Mitra from the University of Pennsylvania will be presenting. Dr. Mitra is a professor of biostatistics and vice chair of faculty professional development in the Department of Biostatistics, Epidemiology, and Informatics at the University of Pennsylvania. She's also the chair of the graduate group in epidemiology and biostatistics and co-director of the Center for Causal Inference at Penn. Her primary research area is causal inference with a focus on developing propensity scores, instrumental variables, and sensitivity analysis methods for observational data with applications in cancer, health policy, and health economics. She's the editor-in-chief of Observational Studies and serves on the editorial board of the International Journal of Biostatistics. She's an elected fellow of the American Statistical Association. With that, I'll turn it over to Dr. Mitra.
Great, thank you so much, Bethany. Welcome everyone. I'm happy you decided to join us for this last session of the day. So as Bethany mentioned, I'll be talking about making causal inference by thinking about trial design, specifically by emulating a pragmatic trial. And so this will be a non-technical introduction to the area. And whoops, for some reason, there you go. So what I'd like to do is just start off by talking a little bit about association versus causation, specifically using the potential outcomes framework. So I'll introduce the potential outcomes framework and talk about how we can think about association versus causation. And then using the same framework, we'll talk about randomized trials and how they differ from observational studies. And then really the focus will be, if you're analyzing an observational study, how can you make causal inference using something called target trial emulation? So first, what do we mean by association versus causation? Well, a quick example is, say in a study they conclude that beta-carotene supplementation is associated with a reduced rate of myocardial infarction in men and women over 65. So a possible interpretation is that individuals who took beta-carotene supplementation tended to experience a lower rate of myocardial infarction compared to individuals who didn't take beta-carotene supplementation. So a very standard way of interpreting an association. But this is very different from talking about causation. So for example, say we have in a study, a study concludes that pre-exposure prophylaxis or PrEP causes a reduction in HIV transmission rates in high-risk individuals. So in this case, a possible interpretation is that PrEP, if hypothetically applied to the entire patient population, results in a lower overall HIV transmission rate in this patient population compared to another hypothetical setting where no one was given PrEP. So you can see here, it's a much stronger statement, but there's these hypothetical scenarios that you need to be comparing. So to dig into that a little bit more deeply, I'll present the potential outcomes framework. But here, just to kind of summarize what we said, in the first example, we were making a comparison of outcomes on the basis of treatment that was actually taken. But in the second example, where we were talking about causality, we were making a comparison of two hypothetical scenarios. So there's the entire population taking or not taking that intervention. And this example helps us to understand what we actually mean by a causal effect, some exposure actually causing some outcome. So we often say that there's no causation without manipulation. So here the manipulation is that we are taking people who are, say, treated, and then we're manipulating things so that they're no longer treated. And then we compare their outcomes. So just with a little picture, we could see that this is association where we compare the treatment received. So in the darker color, we have 4 people that have received the treatment. And in the gray, we see 4 people who did not receive the treatment. And then we just compare their outcomes directly. And that would lead to a claim about association. Causation, again, we're talking about these hypothetical scenarios where we have the entire population, so all 8 of them are receiving the treatment on the left in black, and versus all 8 of them receiving no treatment or the comparison treatment, and they're in gray. And now we make this comparison in these potential outcomes. So we're comparing, again, these hypothetical scenarios. So I'll introduce a little bit of notation. So here we have these different random variables, A, Y, L, and U. This is standard notation in causal inference. So A will be our intervention or treatment or exposure variable. So if it's binary, then if someone is untreated, A equals 0. If they're treated, A equals 1. And then we look at the outcome Y. If it's a binary outcome, then Y equals 0 would be no event. Y equals 1 is they achieve some particular event. But of course, Y could have any kind of distribution. Y could be blood pressure reduction. It could be time to death, time to recurrence of a cancer, things like that. It could be categorical, of course, as well. And then we have our measured covariates. So everything that we were able to measure and potentially adjust for. And L could be, again, binary, continuous, categorical, et cetera. And then we have unmeasured covariates, U. And these are all of the variables that were not recorded or not available to you in your observational study, for example. So now I'd like to present the potential outcomes. So here, what we'd like to first think about is that the treatment has 2 potential values. It could be 0 or 1 if we're thinking about the simplest case of a binary treatment. And now we have different possible outcomes. So Y0 here is the potential outcome under the control treatment, and Y1 is the potential outcome under the treatment. So there are these binary outcomes, Y0 and Y1. For example, if we're thinking of binary outcomes, and those are under these 2 hypothetical scenarios. So these are our potential outcomes. And under a binary treatment assignment, there are 2 outcomes for a given subject, each of which is potentially observed. So one of them is observed and the other is unobserved. So there are a couple of things that we may want to estimate from our study. And one of them is the average treatment effect. That's really oftentimes what we want to estimate. And here, under certain assumptions, we say that we can identify the population average causal effect. And we're not going to go through these assumptions, but I wanted to kind of point out what these different estimands are, the ATE and the ATT. And these are generally defined using differences in means or different contrasts in means or averages across the population. And they do come in different flavors. So there's the ATE, or the average treatment effect. And this is kind of comparing potential outcomes across an entire population. Sometimes of interest is the average treatment effect on the treated. And we'll talk about this in the context of emulated trials. So that's the ATT. And this is really comparing the potential outcomes only amongst those who are observed to be treated. So we're still looking at potential outcomes, but we're subsetting it to only those that were observed to be treated. So let's write the ATE in terms of expectations. So an average treatment effect exists, of course, if the average potential outcome under treatment 1 is different from the average potential outcome under treatment 0. So you would potentially look at the difference, and that would be a risk difference if Y is binary. And you're taking this average, these expected values over the entire population. So again, if you have these binary outcomes, you could estimate a causal risk ratio. So that's really just the expected value of the potential outcome under treatment 1 over the expected value of the outcome, a potential outcome under treatment 0. Or you could even get a causal odds ratio. So these are all different ways of thinking about an average treatment effect. Now, if we're thinking about the ATT, or the average treatment effect amongst the treated, then what we're doing is we are now subsetting to those people who are actually treated, and we're still now comparing the average potential outcome under treatment versus the average potential outcome if they were not treated. And again, this average is taken over the treated subset. So if Y is binary, the difference again, this difference is again a risk difference, and you could always estimate a causal risk ratio or a causal odds ratio. So now let's get back to association versus causation. So in the first bullet here, we're talking about causation, where we're estimating an average treatment effect, where you're comparing the average potential outcomes under treatment to average potential outcomes under control across a population. So this is the null hypothesis that we're testing. We're comparing potential outcomes. Association is much easier, right? You were talking about association refers to the comparison of average observed outcomes. So now we are observing everything. Here we have just Y, no Y0 or Y1. And you're making the comparison between those who are actually treated and those who are actually not treated. So here, we're just comparing what is the average outcome amongst those who are not treated versus the average outcome for those who were treated. So association is a much weaker claim because you're just comparing those who were treated and those who weren't. This causal claim is a much stronger claim. So why might association not be indicative of causation? The treated and untreated subjects can often differ in demographics and clinical characteristics. And so especially if you're using data from observational study, these treatment effects can be subject to confounding, where the treated and untreated subjects, because they're not randomized, may be different, and there could be confounding that you need to deal with. And this is really why randomized trials are the gold standard for estimating causal treatment effects. And of course, by randomized controlled trials, I mean those that have full compliance and have really kind of met all the standards. But the idea is that the underlying randomization theory says that you can now, if there's a well-randomized controlled trial, you can estimate causal treatment effects from that. And this is because the randomization makes sure that the treatment is not confounded with either measured or unmeasured characteristics at baseline. And so the average treatment effect can be estimated by just merely comparing the outcomes between those who are treated and those who aren't. So we can easily get the ATE from when you have randomization. So here, if we write this for a randomized trial, then here we write the ATE here as the expected value of the potential outcome under treatment 1 minus the average outcome of the potential outcome under treatment 0. But since in randomized trials, patients who receive treatment 1 are representative of the study population because of the randomization, we can rewrite this average potential outcome under treatment 1 to be the expected value of the observed outcome, given that you were treated, because those who are receiving treatment are representative of the study population. And similarly, for those who receive, say, the control treatment or the placebo, the average of the potential outcome under treatment 0 is exactly the average of the observed outcome, given that you were not treated. And so you get an unbiased estimate of the ATE, which is just the difference between these two expectations. So randomized trials, we're all clear, we can make causal inference from it. But in observational studies, the treated subjects often differ systematically from the untreated subjects. And so subjects who receive treatment A equals 1 are not necessarily representative of the study population. So here we can't say that the average of the potential outcome under treatment 1 is equal to the average observed outcome, given that you were treated, because those people who are treated are not representative of the whole population. And similarly for the placebo group. So an unbiased estimate of the average treatment effect can't be obtained directly by comparing these two outcomes between the two treatment groups in an observational study. So briefly, using DAGs or directed acyclic graphs, we can see that here A is the treatment. In a randomized trial, since A is randomized, it's not associated with any covariates or variables, whether they're measured or not. And so we could directly estimate the effect of A on Y, or in other words, we can estimate the causal effect of A on Y in a randomized study. Observational studies, of course, are more complicated because this treatment A is not randomized. It can be affected by other covariates. And in this more complicated DAG, this treatment assignment could also be affected by unmeasured covariates. So all of this is to say that L and U could be confounders that are confounding the effect of A on Y. And so you can't directly estimate the causal effect of A on Y. So I just wanted to give you kind of a feel for why you can't directly get causal effects from observational studies without further thinking. And I have to say, when collaborators come to my office, I work a lot with oncologists and also people in health policy. When they come in with an idea for an observational study, the first thing they want to talk to me about is how do we adjust for confounding in our observational study? And they want to jump to propensity score matching or inverse probability of treatment weighting, maybe even instrumental variables. And these are kind of at the analytic stage, really. And you know, all of these approaches do require certain assumptions. We call them identification assumptions. And some of them only take care of measured confounding, like propensity scores. Instrumental variables can, you know, get at unmeasured confounding as well. But before we jump to the actual analytic plan, what I really encourage my collaborators to do is to think more carefully about the design of the observational study first. And more importantly, what I try to do is sit down and think through how we can emulate a clinical trial, because there are all those advantages to a randomized trial, right? We could get the average causal effect from that. So the idea is that when we use data from observational studies, we're often doing that because the ideal randomized trial, what we're going to call the target trial, is not ethical or feasible. But if we could try to emulate this target trial, like our dream trial, like if we could actually run it, if we can emulate this target trial successfully, our analysis of the observational study should give us the same results as that target trial if it could have been conducted. So before you jump to the analytics of propensity scores and IVs, et cetera, let's think carefully about how we could utilize the data from the observational study to emulate a target trial. So one example that I recently worked on was with a radiation oncologist, where we wanted to estimate the effect of radiation versus chemotherapy in the treatment of endometrial cancer in post-hysterectomy patients. So before we jumped to let's do propensity score matching, which is what they wanted to do, I said, you know what, let's think through the steps we need to take to emulate the target trial that we wish we could have conducted. It's not ethical or feasible at this point to randomize women who have had a hysterectomy and who have endometrial cancer to radiation or chemotherapy. It's not possible. But can we take the data that we have from the National Cancer Database, the NCDB, and emulate a target trial? So here I'm going to briefly present the 7 steps for trial emulation. And these are very nicely outlined in Miguel Hernan and Jamie Robbins' paper in 2020 that's in the references. So we're going to talk about the framework, and I've split it up into 7 steps. So the first is determining the eligibility criteria. So of course, like if we're emulating a target trial, of course we want to think about who would be eligible and who wouldn't be. So you want to start by thinking, when you're setting up your observational study, to very carefully, just like you would with a clinical trial, think about who would be eligible. And you should be using the same eligibility criteria that you would for your target trial, that dream trial. But there are quite a few challenges that you should think through. First, when you're using observational data, you have to remember that you can't use criteria that are eligibility criteria that are based on events happening after baseline, because those restrictions couldn't have happened at randomization in a trial. So for example, if you say, well, I'm only going to include patients who survived 3 months beyond treatment in this observational study, that does not emulate a trial, because when you're conducting a clinical trial, when you're randomizing them to these two treatments, you don't know what's going to be happening after randomization. So your eligibility criteria should not be based on anything happening after baseline, even though I've seen that many times. Also, when you're running a clinical trial, the participants are often followed through their healthcare provider and are randomized once they've committed to the length of the trial. So they're agreeing to join a trial. They understand the trial is going to run for, say, 2 years, and they're committing to that. In an observational study, that's hard to determine. So if somebody is actually, you don't have much follow-up or any follow-up at all, oftentimes those people are just dropped from the observational study. But if you do that, you could have a lot of bias, and if you just exclude patients who don't have, say, claims in a database. So they should be actually considered censored. One option potentially, if you have really good observational data or maybe EHR data, is to restrict the data to those who have been in regular contact with their provider prior to baseline, and then assume that they would do so afterwards. So just like in a trial where you're assuming that the participants are going to continue in the trial for the full length of the trial, somehow being able to determine patients who would have complete follow-up. If they don't, though, in the database, they should be considered censored and not just dropped from the study. We need to determine, of course, the treatment definition. That's step 2. And typically, the emulated trial, the trial that we're trying to emulate, is a pragmatic trial, in that the treatments are compared under practical situations. So in other words, the physician or the clinician that's prescribing the treatment and initiating the treatment knows which treatment they're giving, for example. So the other point I wanted to make is that after eligibility is met, each woman is assigned to, say, radiation or chemo in our study, but others who are eligible for the trial but did not start either therapy or had combined therapy would be excluded. So we are kind of determining the treatment definition very specifically, again, trying to emulate our dream trial. And in this case, if we did that, we would not be estimating the effect of treatment in the entire population of eligible women, but only amongst those who would have chosen to participate in this particular emulated trial, where only 2 treatments were would be randomized. One thing to think about is we can't really emulate a placebo-controlled trial with strict adherence. When you have observational data, it's tricky, right? Because a comparison of never users to current users doesn't really line up with any kind of randomized trial that you would design. You are really randomizing to one treatment arm versus another treatment arm. So if you are the placebo-controlled trial where there's no users, say women who aren't receiving radiation or chemo, who are they? They're the never users, but they would. How do you line them up in terms of designing a trial? Step 3 is defining the treatment assignment. So I mentioned the blinding. So we can't emulate trials that have blind assignment, of course, but that's fine since we're emulating pragmatic trials where healthcare workers know what treatment they're giving. And to emulate random assignment, we do need to adjust for confounding so that we can achieve exchangeability. In other words, we want the treated subjects and the control trial subjects to look the same, so they're exchangeable. And this is where propensity score weighting or regression adjustment or matching or other machine learning tools could be implemented. And there, of course, could be unmeasured confounding that you need to deal with, again, to achieve this kind of, to emulate random assignment. So you may want to think about instrumental variables, using maybe negative controls or sensitivity analyses, but different ways to think about confounding. Step 4 is to define the outcome. So it's often preferred to emulate a trial where the ascertainment of the outcome is not influenced by the knowledge of the treatment status. In a randomized trial, of course, everyone is followed up. There's a strict protocol on how to assess the outcome. In an observational study, for example, this may not be true, but say in our example of radiation versus chemo, say the physician looks more carefully for cancer recurrence in radiation patients versus chemo patients, then you are now ascertaining the outcome in a differential way. So those are things you should really think about when you're using observational data to define the outcome. And of course, one exception is if the outcome is death, because that's usually independently ascertained from a death registry. So it's easier to emulate a trial using observational data in terms of defining the outcome if death is the outcome. This is a tricky one, defining time zero or baseline. You have to think very carefully about how you do that. So in a target trial, your baseline time is when the treatment strategy is assigned, when you have that randomization, which is either usually shortly before or at the time of the initiation of treatment. But in an observational study, there was no randomization. So usually the best strategy is to define time zero is the time when an eligible patient initiates treatment. I have seen a lot of studies where people, when they're using observational data, think of baseline as the time of diagnosis, and then people may be treated at different time points. But that's not really emulating a trial, because we want to really start the clock when someone is getting treatment, because that is emulating the randomization. And we may actually miss out on a lot of events that are happening between diagnosis and treatment, or vice versa. There can be some complications because the eligibility criteria could be met at multiple times. And so in the Hernan and Robbins paper, they have a nice example of where they're looking at initiation versus no initiation of hormone therapy amongst postmenopausal women. And a woman can meet the eligibility between, say, ages 52 and 60. So when should her follow-up start? So that, you can imagine, is quite complicated. In a randomized trial, of course, they just start when they enter the trial and you randomize them to hormone therapy or not. Here, the eligibility says any age between 50 and 60. So when does the clock start for these women? So you could standardize things by picking one single eligible time, or more complicated, you could emulate multiple nested trials. So time zero is a complicated thing to think very carefully about. Now, we want to choose the causal estimand. That's step 6. So in randomized trials, causal effects include intention to treat or per protocol effects. And if these are of interest in the target trial, then what we want to do is really estimate these from our observational study. But the ITT, or the intention to treat, is not often possible to estimate in observational studies because there was no randomization. Here, the intention to treat is, of course, you're analyzing the outcomes as if everyone stuck to their randomization. It's the as randomized effect. You could potentially estimate the ITT if you have data on prescribing a treatment rather than receiving the treatment. And then we could really compare the groups depending on whether they received a treatment prescription at baseline. And the NCDB, we do have some data on when something was prescribed, whether or not someone actually took that treatment. So you could potentially get at the ITT if you have that information. And then finally, this is where people often start when they come to meet with me, but this is really step 7, is making a statistical analysis plan. And here you want to consider carefully, say, for example, you're estimating the per protocol effect in an emulated trial. You want to think about adjusting for baseline confounders, adjustment for post-baseline factors associated with adherence to treatment. So you might want to use some G computation methods. You need to think about accounting for loss to follow-up and censoring. You have to think about how to deal with missing data, whether the missing data are informative or not. And you also need to think carefully about measurement error. So the step 7 is after you go through all those other 6 steps, really to be able to get causal inference from your observational study. So I just wanted to summarize by saying that target trial emulation is consistent with formal causal theory of counterfactuals. It provides an organized framework for using causal methods for observational data, clarifies reporting of results from observational studies, just like you would publish, say, a protocol for a randomized trial. You could always publish a protocol for observational studies. And I'm going to put in a little plug for the journal that I'm editor and chief of. It's called Observational Studies. And we do have a special section that publishes protocols for observational studies. Target trial emulation does help to directly compare and evaluate results from different observational studies. And one of the key points is that if you're emulating a target trial, this can really help to explain differences in results between different observational studies. You see this all the time where different observational studies are getting different results. Well, part of that could be because they were just emulating different target trials. It's not because anything was flawed in the analysis or even in the design. It may just be that they were emulating different target trials. And so these are just some references. The first one, the third one is a very nice paper on using big data to emulate a target trial when a randomized trial is not available in AJE. So I will stop sharing and I'm happy to take questions.
Thank you so much, Dr. Mitra. That was fantastic. I've always been fascinated by directed acyclic graphs, and it really resonates with my behavioral science background and thinking about all of the many inputs on human behavior and health outcomes. I was wondering if you could talk a little bit more about where are all those hypothesized relationships come from? How do I identify the source of instrumental variables and potential confounding?
Mm-hmm. Yeah, it's a really good question, Bethany. And that's another thing that I like to do when we first sit down to talk about a study is to really draw out a directed acyclic graph, because it really helps to kind of think through not only what are potential confounders, but also think through that some of them could be mediators. And also some could be time dependent. So some of these very confounders could be affected by the treatment that patients are receiving. So to kind of draw out that DAG really helps. It also could point to other things, like you may have some confounders that you would automatically want to adjust for because you think they're confounders, but once you draw out the DAG, you might end up realizing that that's a collider. And you have something called M bias. And then if you actually adjust for that, you could actually really mess up your treatment effect estimation. So drawing out that DAG, in addition to kind of going through the trial emulation steps really helps.
There's a question in the chat here. Are the sample size and power considerations in target trial emulation, or what are the sample size and power considerations?
Yeah, that's a really good question because it's part of the design and the protocol of creating an observational study. So I would go through all of the steps first to really determine what kind of trial you want to emulate. And then once you've defined the confounders, the outcome, and the analytic approach, you can then do a sensible power calculation to be able to be able to have enough power or to see what kind of treatment effect you might be able to detect. The challenge there is you have to hypothesize how those confounders may be kind of acting on things and how strong those confounders are, because that's going to influence how your signal versus the noise. Unlike in a randomized trial where you can ignore confounding when you're doing your power calculations. That's a great question.
Wonderful. Well, thank you so much. We have just 1 minute left. I just want to thank everyone for attending COPRH today, and thank you for your presentation. We really hope everyone enjoyed the talks, and we'll come back tomorrow. Tomorrow there'll be a lot more presentations on data sources and managing data, and really figuring out how to prepare data for analysis in pragmatic trials, including in emulated trials like this. And so we hope you all come back and can really dig into how to do this and how to do it well. So thank you, everyone. I hope you have a great evening.